We're back in the DermCast studios in Boston, Mass. It's Rob Casquejo, and today I'm here with two friends and colleagues, Peter Young and Cynthia Griffith. Today they're going to talk about the year in literature review. Welcome, guys. How you doing?
Thanks, Rob. Doing
well,
great.
I'm going to take. I'll give you guys a second to let people know who you are, and if you want to just explain your roles in leadership and academics.
Yeah. So I'm Peter Young. I'm a physician assistant at Kaiser Permanente in the dermatology department in Sacramento, California. I also am a visiting scholar at Stanford University School of Medicine in the derm department, and I like to write for peer-reviewed derm journals. So I do research outside of my day-to-day job. I volunteer for a couple of SDPA committees for the JDPA and the Diploma Fellowship committees and the Communications Committee.
And Peter's also the SDPA DermPA of the Year.
Right.
Award winner.
Congratulations on that. That's
Thanks.
awesome. It's great to have you here in that context as well.
Pleasure.
Yeah.
My name is Cynthia Griffith, and I'm a DermPA. I practice in Dallas, Texas at the University of Texas Southwestern Medical Center. I see organ transplant recipients, and I volunteer at the Society of DermPA's journal as the editor-in-chief of the Journal of Dermatology PAs. Thanks for having me.
Yeah, thanks for being here, guys. So your backdrop, it's obvious why you guys were in this position to give us this literature review today, and there were some great things that we saw in the lecture. So we're going to try to cross as much of it as we can. So why don't we just jump into it, and you can start. Cynthia, you reported on some research about the workspace for physician assistants these days. Why don't you tell us about that?
So we did a study using NCCPA data to look at how DermPAs work in the United States. And we found that DermPAs are efficient. They see more patients while working less hours than any subspecialty. They're also not burned out. So it's a great piece of the puzzle as far as looking at derms, PAs, and how they fit into the workforce.
Great. So it just sort of validates at this point that we're working efficiently in the medical space, and for the most part, it sounds like we're pretty happy doing it.
That's right. And also, our patients are happy. So we also have a study coming out next month, Peter and I, showing that 12,000 patients are as satisfied with DermPAs versus board-certified dermatologists with regards to their medical visits and their medical care. So patients are satisfied with the care they receive. They're more likely to recommend them as their care providers. So it's an exciting thing to know that our patients are satisfied with the care we give them.
That's great. And when's that publication coming out?
Next month.
Okay, great. We'll look out for that one. That's awesome. Okay, so let's turn to what we saw on the medical side in the literature in the last year. So Peter, why don't you go ahead and tell us, I think one of the topics was eczema. Why don't you tell us about what we found there?
So in the family of eczematous dermatoses, allergic contact dermatitis has some interesting papers this year. Namely, there was a paper in the JAD and JAMA Derm looking at ingredients in hand sanitizers and natural skincare products, and each of those have a high number of allergens that people commonly become sensitized to, even if they are labeled as hypoallergenic. So important for patients to look at the ingredients, not just the marketing claims.
That's important because those are things that we're using very frequently these days in all our households.
Yeah, and we also looked at a paper about the intelligence testing scores of children with atopic dermatitis who basically perform lower if their eczema is poorly controlled. And so it's just another piece of evidence for us to sort of understand the greater importance of treating somebody's itch. It could improve their trajectory for their education and career if their eczema is well controlled.
Right, and it's an important quality of life index, right, for children in their academics as they, going through the normal rigors of school to deal with such a really bothersome chronic disease.
Yeah,
right?
Yeah, and the last couple of eczema-related papers that we looked at were related to the safety and efficacy of the newer systemic therapies for eczema. So a few new JAK inhibitors, abrocitinib, ubetasitinib, and baricitinib, all have good efficacy for eczema, as well as a new IL-13 inhibitor, tralokinumab. So all of those are relatively new and showing some promising efficacy and safety in the latest research.
And because there's such new therapies, it's always it's a good thing that we need more literature, more experience as we get comfortable with these medications. Right. Okay. And then I think there was we also saw some new information for psoriasis in context of a couple interesting things. Why don't you go ahead and start and tell us what we found in psoriasis?
So one of the things that we found with psoriasis was that the question of people that had the COVID vaccine, if they were on treatment for their psoriasis, on immunomodulatory drugs, did they mount an immune response to the vaccine, and how strong was that immune response over time? And so a question that was more on our minds, I think, about a year ago, but now we have the answer, which is that both groups, people on medicine and not medicine for psoriasis, had an increase of immune titers, so they responded to the vaccine. But it seemed the people on TNF-alpha inhibitors seemed to decrease their response, their immune titers over time. So they became a little bit, they decreased from the control group with regards to their ability to maintain immunity to the vaccine. So potentially the clinical implication would be that they get vaccinated or boosted a little bit sooner than the 6 months versus waiting for 6 months to come around.
So what I'm hearing there is those on a biologic got their vaccination, they acquired immunity, but it just sort of wore off a little faster than those who were not on a biologic. Okay, so that now I think that's very practical, because there was all these questions in the front end of the pandemic of is it safe to stay on a biologic? Will it affect immunity? Will it affect the vaccine, et cetera? So we have a little bit of information, some answers there on the context of that.
That's right.
Great, very interesting. And then there are some interesting things about malignancy as well with the psoriasis in context of other comorbidities. So tell us about that.
Yeah, so we looked at a study that looked at people that have psoriasis who have had clots and what is their increased risk for development of cancer. And we saw that these patients do have an increased risk of cancer. They have an increased risk in the first year, so the thought maybe they had an occult malignancy that caused their clot. But then that this was a real thing that they saw over time. Basal cell and lung cancer tended to be higher in these patients. So the practical takeaway would be think about age-appropriate cancer screenings for your patients that have psoriasis.
And hopefully that's being done already, right? We have people on multiple therapies that can be, in theory, increase malignancies. They're either on label warnings or they're just part and parcel to the therapy, like UV therapy, et cetera. So I guess this is another study to validate the inflammatory nature and comorbidity risks associated with something like psoriasis.
That's right.
Yeah.
My favorite study that we found about psoriasis was a study that you can utilize when you're trying to advocate for your patient to be on newer psoriasis therapies. It was a study that looked at the cyclosporin, acitretin, methotrexates, and found that over the course of a year, 50% of people don't tolerate the medicine or it's not effective. So they have to switch to a different medicine. That citation found in the British Journal of Dermatology from May last month is going to be helpful, I think, when you're trying to write prior authorization letters for your patients.
And that's big value there. I think everyone should get a copy of that link or a photocopy of it, and with every adjudication process with insurance, just send the article.
Absolutely.
And, just to back you up when you're trying to get those medicines covered. That's great. Anything else in psoriasis?
Well, there were a couple of papers about the safety and efficacy of bimekizumab, which is a new IL-17 inhibitor. So it looks like it's a little bit more effective than secukinumab or Cosentyx. And the downside is you're more at risk of oral candidiasis on bimekizumab. So about 1 in 5 patients get oral candidiasis during the first year, and that's something to counsel patients to look out for if they're going to go onto that therapy.
That's great. So we've been waiting for bimekizumab for a while now. So now we've got the data. It looks like through the FDA that the launch is going to come. So we've got the background information now before we start seeing that medication available. So great, fantastic. So you guys mentioned the COVID vaccination in context of psoriasis therapies. So there's some interesting things of the COVID in relation to melanomas. What did you guys see in the literature?
So we saw that actually, as a result of the pandemic, there was a delay in diagnoses for melanomas, resulting in thicker melanomas by Breslow depth, melanomas that had higher ulceration and mitotic rates, and melanomas that were stage 3 and stage 4 at a higher rate than before the pandemic.
Wow. So this is, it's sort of this hidden now risk, aside from dealing with the morbidity and mortality of the pandemic itself. You have this sort of trickle-down effect and worsening prognoses for these cancers that we see in our offices. So, gosh, that really, how do you think that affects what we do on a daily basis?
Yeah, so I think it's sort of like a ticking time bomb where potentially there are people that haven't yet come in for their screenings, but they are growing melanoma during that time. We see this in colon cancer, cervical cancer, and thyroid cancer, where we have studies that actually show that we're seeing the same thing in those cancers.
Right, so it's sort of nearly across the board with all malignancies due to the delay of care from the pandemic.
I think it'll be something that we look back at 10, 15, 20 years from now and kind of see that bump in sort of these higher stage cancers due to that period of time we weren't able to screen people adequately.
Right, that's unfortunate. Another unfortunate side effect of the pandemic. Well, speaking of melanoma, there was some data about the diagnoses or perhaps overdiagnosis of melanoma.
Right.
Tell us about that, Peter.
Yeah. So obviously it's important for us to start getting this backlog of undiagnosed melanomas into the clinic and to start screening these patients for melanoma. But the downside of increased screening pressure is that it appears over the last 40 years there has been possibly a lowering threshold to diagnose melanoma, because we've seen a rapidly rising rate of the diagnosis of melanoma, especially in situ melanomas, while the mortality associated with that has remained basically flat. So if we're catching more and more cancers, but we're not saving anybody new, then the question comes up: Are we harming people with this diagnosis? Are we not actually helping them? So some recent literature suggests there's an epidemic of overdiagnosing melanoma, but we need more data to figure out which of these melanomas were truly going to harm the patient if they had been left undiagnosed versus which of them maybe will in the future not be called melanoma if diagnosis improves, perhaps through new technology.
And that's such a tough topic, right? Because it's really hard clinically to just ignore, let's say, in a melanoma in situ. It's just really tough to come to terms to say, like, maybe it's not so bad, or maybe this really isn't melanoma. I mean, it's sort of what we're talking about here.
Right.
So that's really interesting. I imagine that one probably is controversial, probably from clinician to clinician.
It certainly is a hot topic. I think it's a hot topic for people behind the microscope and people that are looking at patients. So I think it's certainly one of those kind of just good papers to know about because it was 40 years of data. I think they did a great job looking and drilling down, but it certainly has a little bit of a controversial
tone to it.
Yeah.
Right.
One thing we can say that we're helping a small percentage of patients with mortality. So around 2014-15, we start to see a small decline in the mortality from melanoma, and that's specifically because of checkpoint inhibitors being introduced at that time. So for the more advanced stage melanomas, patients who get checkpoint inhibitors now have a much greater likelihood of survival. And a paper in JAMA Derm that we looked at sort of compared the survival rates of these checkpoint inhibitors, so patients on these therapies surviving melanoma, compared that with the side effects in the skin that they have. So rashes, itching, etc. A lot of patients get cutaneous adverse reactions from these medicines, and those side effects are associated with greater survival. So if your patient comes in with a bad rash from their checkpoint inhibitor for their melanoma, we can at least reassure them of the silver lining that their rash is a sign the medicine is working and they have a higher likelihood of surviving.
Right, and it reminds me of using something like a topical chemotherapy, that if it fries you, at least you know it's working, right? So that's promising, and the checkpoint inhibitors were a rare victory in oncology. We don't get enough of those kinds of victories of how it changed outcomes for those with advanced melanomas. So
it's been a game changer for a lot of these patients.
Absolutely.
I tell patients it's the best time in history to be diagnosed with melanoma because we have these newer treatments where it's not the death sentence that it once was. And so I think it's an interesting paper because we're also going to be seeing those patients with these cutaneous manifestations to encourage the medical oncologist and the patient to continue therapy, and that we can treat their cutaneous manifestations, but this means they're in a good place prognostically with regards to living longer due to their PD-1 inhibitor treatment.
Right, so we have reason to give hope to these folks. So all of this is fantastic information. We know how important the literature is because medicine is an evolving discipline. We always want to know what's new and what's changing. So in context of literature, publishing, the medical literature, where do PAs fit into this?
Well, I think that PAs fit into the derm literature the same way that physicians and dermatologists do, if you want to. You can be an author, you can be a principal investigator, you can be an advocate or a researcher, and there is a lot of value in choosing to author or co-author papers in derm peer-reviewed journals because it's a great way to learn about new therapies that are coming out. It's a great way to understand where the information comes from that you have been taught in school or in textbooks. It's a great way to just deepen your appreciation for the specialty and then be able to teach it that much better to your patients.
So let me push back a little bit on that in the sense that the average PA, we're usually working, we're not necessarily involved in situations where we can do controlled study. What would a PA, what kind of things would a PA publish in literature?
Yeah, the best place to start is a case report because a case report is basically just a polished, nice version of a visit encounter note that you would write. The subjective, objective, your assessment, and your plan. And if you can write a SOAP note, you can write a case report. The difference is just finding a case that has some teaching value for other people or that has something novel and interesting that other people would also like to learn and hear about.
That's great. So because we're doing these things every day, you're just taking something that you did and putting it into a story format, essentially. So if I want to do that, how would I go about doing it?
Well, I would say PAs are collaborators. Find a collaborator, whether it's your medical science liaison, whether it's the JDPA, reach out to that person. And JDPA's website, we have templates as well that you could utilize to get started. Looking at past case reports from the journal that you are interested in publishing in is also a good roadmap. Match the format as far as the headings of what is published in that journal, and that's a good roadmap for how to start writing your case report. But don't forget that you don't have to do it alone. You can reach out to a colleague that's published before, like your medical science liaison, especially if your case report has to do with a therapy that you tried for a patient, or to the JDPA to be an additional resource. We have experienced writers that can partner with you to publish those reports.
So and ultimately, whatever you submit, there's going to be some sort of editing process that someone can help you through to fine-tune the publication.
Yeah, so we call it peer review, and we send the manuscript that you submit to experts within our community in that subject matter to really understand, is this appropriate, is it factual, and then reviewing and providing feedback on how to make this better as part of the process, to refine the manuscript before it becomes a published medical literature article.
Ultimately, PAs, we're in a position where we can and should be contributing to the updates in literature and the progression of medicine at large.
Yeah.
That's great.
We see a vast amount of patients, and we will see these unusual manifestations or these interesting treatments. We're treating our patients and seeing interesting and novel clinical responses, and we should be putting that into the literature.
Great, awesome.
And there's also a lot of misinformation in the literature about DermPAs, not because authors getting published have ill intentions necessarily, but because many who are contributing to the research just don't have exposure to PAs during their training. They don't actually have firsthand knowledge or experience about the training that we go through. And so there's a lot of misinformation that gets printed, and if we are writing letters to the editor or generating new articles, we can help these friends and colleagues to understand our training and qualifications better and feel more confident and at ease about partnering with us in caring for patients.
If you're reading an article and you see that something maybe is not true with regards to what a DermPA can do or how a DermPA is trained, you could write a letter to the editor and lend your voice to that conversation to correct that factual error that you see. That's what our writing and our scientific process is about, and this is the next step in PAs, adding our voice to that conversation.
And literature ultimately should be neutral, right? It's information. It's supposed to be objective, and so we if there's objective information that may be inaccurate, the best way to correct it is to be objective in return.
Yeah, yeah. And the people who are writing research in big name journals, most of them sincerely care about objectivity and having truthful information in their writing. So they often appreciate being corrected in the same way that you might appreciate being corrected on maybe misstating an element of your medical understanding of a disease or something. Like if I said something wrong about hidradenitis and Cynthia corrected me, I'd be grateful to be, truthful and correct in the future as a result of that help. So it can be well received to help these people to sort of get on the right track.
Fantastic. That's all really good information. So let's end by saying this for our viewers. If someone wanted to be published, let's sort of go through a laundry list of how they might go about that. So what's step one?
So if you're clinically practicing PA, step one, in my opinion, is write down the MRNs of patients that have cases you think are challenging or interesting that other people might learn something from, and save that list in a secure place so that later you can refer back to the record and see, did this case turn out 3 months later to be what I thought? Does it have teaching value? And whatever sort of cases survive that process of months later being still a good teachable case after you see the outcome of the treatment, write a rough draft of the case report based on basically your SOAP note and the medical record, and you can refer to an article in The Dermatologist that I wrote with some friends that teaches people step by step how to write a good case report and where they can submit it from there. It's called 10 Essential Tips for New Authors in The Dermatologist magazine.
Additionally, at that initial clinical visit, I like to think about, you've identified a patient that you think is an interesting case, getting them to sign a consent form, and we have those uploaded on the JDPA website that you could download, and have the patient sign a consent form, taking good clinical photographs. A picture is worth 1,000 words. So you've identified the patient, had them sign a consent form, and then taken good clinical photographs. Then you have your documentation, and then the back end is just polishing that to ready it for submission.
Okay, so we have the collection of the data in the case. So that's a time involved process, right? So from beginning to end. Then we have we have resources through the SDPA on a sort of prep work, like getting consent, and then for submission, what's that step in terms of submitting it?
So there's a website that Cynthia and I sort of co-run together called the Collaboratory for Interprofessional Authorship in Dermatology, and the website is ciaderm.org. That has a list of helpful resources explaining the submission process. I think there's some resources on the JDPA page as well. And the submission process is a little bit different for each individual journal, but if you simply Google in like quotation marks author instructions and then the name of whatever journal you want to get published in, so the JDPA or the JAD, usually the first or second results on Google will be a detailed set of instructions as far as the word count limitations, the number of figures that are allowed, and then sort of a click button for submitting the manuscript to that journal.
Okay, so that doesn't sound nearly as complicated, I think, as people might think. And for the viewers, I'm going to make sure we put those links in both those links that you mentioned, Peter, so that they have a resource to go to, and let's see if we can get some PAs published, right?
Yeah.
All right, awesome.
Absolutely. It's easier than you might think. The first one, I thought, my first time, I thought was very painstaking and difficult and miserable, but the second one, much easier, and from there, it's smooth sailing, and anybody who can graduate PA school can get published.
And I would encourage people to collaborate or even reach out to somebody who's done it to kind of shepherd them through the process. Even just a simple, which journal should I submit to, can be insightful to talk through that with someone to find, is it more appropriate for perhaps this journal versus that journal? Because a lot of the way you can be set up for success is thinking about even just simply what journal you're going to submit your article to.
That's great, and I would in that regard, I would make a plug for the JDPA because obviously very friendly to us at large, and some great resources in terms of getting those case reports published. Well, thank you so much, guys. This has been a wealth of information. The medical updates and the context of putting PAs out there to get published. So this is all very important things, and hopefully our viewers will take something from this, and we'll start seeing some clinical changes from the information you gave us, right? And hopefully we'll see some PAs encouraged or inspired to get into the literature. Thanks again for coming, Peter and Cynthia. It was great to have you here in the studio.
Thanks for having us, Rob.
All right, awesome. And thank you for watching Dermcast TV. It's Rob Casquejo.